Good morning to you all. Let me begin this year's first academic session by wishing you all a very happy new year that will bring happiness and contempt in life. Today's topic is falls in older adults. I know it's something that we are not very familiar with, but I'm sure each and every one of us in the primary care might have come across older patients who has had falls. And I think this lecture might improve our horizons in regard this. And our resource person is someone very familiar to us, Dr. Sithira Seneviratne. Dr. Sithira is a board certified geriatrician working as a consultant geriatrician in the National Hospital Sri Lanka. He's a graduate of the Faculty of Medicine, University of Colombo, and completed his MD in geriatric medicine. He was a former fellow in geriatric perioperative medicine in Oxford University Hospitals. His research interests include orthogeriatrics, perioperative medicine, geriatric palliative, and end-of-life care. So without further delay, let me welcome Dr. Sithira to commence the lecture, as I wish him a splendid new year as well. Thank you.
If you go through the stats about population aging, we all know that global population is aging. And in fact, if you look at the data in Sri Lanka, so Sri Lanka has the fastest aging population in South Asia. And if you look at the graph, you can see now in 2003, we had only 8% of our total population more than 60 years, which has now grown up. It's predicted in 2025 it will reach 21% of total population being more than 60 years. And in 2041, 1/4 of our population will be more than 60 years. So you can see from 8% in 2003 to 25% in 2041. Very rapid rise of older population in Sri Lanka. So this will have a lot of implications on their health, and as doctors, I think all should be aware about what problems the older adults will have and what kind of treatment we can offer. And if you look at further about this data, you can see the female population is more than the male population. And they will be more octogenarians. So that means the older adults between 80 years and 90 years. Mm-hmm. Right? So that's the fastest aging group at the moment. So there will be a lot of female octogenarians in coming years. So that's the population trend. Right. So coming into the topic today is about falls. Yes. So fall by definition is an event which results in person coming to rest unintentionally on the ground. Okay, so that's quite clear. And so if someone is having 2 or more falls within last 6 months, we define it as having recurrent falls. Okay, right. Recurrent falls. And even though this is the definition, you might not be still clear about what geriatric fall really look like. So I have put this video. I'll give you a minute to look at this video and get an understanding about geriatric falls. All right. So what did you think happened there? So if you think about the type of fall or the cause for the fall, do you think it's an accidental fall? Do you think it's a mechanical fall? Was it a slip and fall? Was it a syncope? Was it due to loss of balance, or was it multifactorial geriatric fall? Right. So that's what we are going to discuss today. All right. So things like accidental falls, mechanical fall. So those terms are going out of fashion now. Right? So they are sometimes misleading, and really doesn't give you an idea about the mechanism of fall. So most of these falls are multifactorial. Basically, if you think about what happened in that video, the patient, it was an older patient, probably with loss of balance and possible other multiple factors like muscle weakness, joint instability, and there were some environmental factors as well. The chair was The wheelchair was sleeping, or yeah. So most of these faults are multifactorial. Okay, so how common are faults? Why are we discussing today about faults? So if you look at the global data, every 45 seconds one older person die of a fall. Okay, and it's estimated that one third of all adults more than 65 years will have a fall at some point, and half of all adults more than 80 will have a fall as well. Most importantly, what you have to remember is, if you have one fall, that exponentially increase the risk of having another fall. So people you see in your emergency department, in your outpatient clinic, who had a history of fall, are the people who are going to have another fall in subsequent weeks, months, and years to come. All right. So people who fall have an exponentially high risk of falling over again. So you have this window of opportunity, all right, to assess them comprehensively and take actions to prevent a fall. Okay. Just another reminder about the geriatric giants. I discussed this in my previous lecture as well. So falls is one geriatric giant. So together with instability, immobility, incontinence, impaired cognition, and iatrogenic illnesses. Right. So just as a start, I'm going to discuss about a case history. This is about a patient named Mr. Silva, who is an 80-year-old gentleman who is admitted to accident service following a fall last night. So he describes his fall as a tripped over, okay, and fell on the ground. And as you can see, it was dark at that point, and he couldn't remember where he left the walking stick, and so decided to proceed without the walking stick. And he claims that he had some lightheadedness which resulted in a fall. So after the fall, he got severe pain in the right hip, and he was unable to get up and decided to lie on the floor until help arrived in the morning. And in the accident service, he was found to have right side hip fracture. So unfortunately, this fall resulted in hip fracture. So today we are not going to discuss about hip fracture, but just to remind that falls can result in a lot of morbidity and mortality. If you think about the impact of falls, so there are physical and there are psychological consequences. All right, and this causes higher level of dependency and mortality, and obviously high healthcare cost. Right. So thinking about the consequences of fall, if you look at the physical consequences, there will be simple skin tears, but there will be severe complications like internal bleeding, subdural hematomas, hip fracture, and then looking at the psychological consequences, most of these patients develop fear of falling, having after having one fall. So that affect their level of mobility and subsequently lead to more deconditioning and more falls. All right, and increased dependency, related to depression, anxiety, loss of confidence, which result in social withdrawal. Okay, right. If you look at the hip fractures, so most of the hip fractures are due to falls. All right, so 90% of hip fractures are associated with falls. Right, and hip fracture in old adults are associated with high mortality. All right, if you look at the data from the developed countries, this mortality rate can change from 20% to 30% within 1 year after hip fracture. So we have limited data in our setting, but the mortality is in fact higher than those figures. So the high risk of dying if you have a fall and a hip fracture. That's why it's very important to prevent a fall. Right. So this is what I discussed. When you had a fall, what happens is you develop fear of falling, and this leads to lack of confidence and further restriction in daily activities, and leading to more dependence, more deconditioning, and this is the trajectory is downwards. This is called post-fall syndrome, and this is kind of a cycle. We call it fear of falling cycle. As I described earlier, fall resulting in fear of falling and less activity and decreased muscle strength and balance, and then increased risk of falling again. And if you don't intervene, this is going to be a downward trajectory, okay, resulting in more and more falls, ultimately resulting in hip fracture or some other complication. Right. So now if you think about the case history, the Mr. Pereira who who had a fall was lying on the floor until help arrived in the morning. So unfortunately, this could be the situation in most of our old adults who are living alone, right? And if you lie on the ground for more than 1 hour after a fall, we call it a long lie. What's the problem with a long lie? So if you have a long lie, there's a high risk of developing hypostatic pneumonia, pressure ulcers, rhabdomyolysis, and sometimes hypothermia. All right? So but this duration depends on the nature of the floor as well. If you are lying on a very hard floor, even less than one hour time, you can develop things like rhabdomyolysis, pressure ulcers. So lying on the floor after a fall is associated with a lot of complications, and in fact later on a lot of morbidity and mortality, right? So just a reminder, if someone is having high risk of falls and living alone at house, if they have a fall, so there's a high risk of mortality because of these things after a long life, right? So if you think about the types and causes of falls, all right, so there are several classifications. If you think about the circumstances, these could be indoor falls, these could be outdoor falls. Some falls are associated with loss of consciousness, some falls are associated with intact consciousness, right? And if you think about the mechanism of falls, most of the falls, more than 90%, is multifactorial geriatric falls in older adults. So, but there are clear slips and trips, and sometimes people fall because of the external forces, and sometimes there could be acute medical problems as the precipitating cause, such as syncope, seizure, hypoglycemia, and there are other causes, rare causes as well, right? So, if you think about these patients who develop loss of consciousness following a fall, so there are again several differential diagnoses. So, people can lose consciousness and fall. Either they can fall and they can hit their head and then fall. So, and these people might have retrograde amnesia, might not able to remember what exactly happened. So that's a very challenging situation. But we usually ask if the patient can remember hitting on the ground, just to differentiate whether they lost consciousness before had the fall or after having the head injury. So differential diagnosis for a patient who lost consciousness could be, it could be a syncope, it could be a seizure, or it could be a vascular event, or if it could be a head injury after the fall, right? If you look at the falls history now, it's think about a patient with a seizure. So how do we take history? We divide the components of history as pre-ictal phase, ictal phase, and post-ictal phase. So likewise, so we can divide these the duration of the fall into three phases: pre-fall, and fall, and post-fall. If you look at the pre-fall phase, so sometimes if you ask in the history, some of these patients will tell, I was feeling giddy, right, before I fell. So it's something to do with sometimes low blood pressure. So postural hypertension is quite common in older patients, right? And so some people would say, so I had vertigo, all right? So some would say I had a chest pain, I had palpitation. So the pre-fall, what symptoms patient had is quite important to ask. And if you ask about the activity prior to fall, some of these people, they fall when they are getting out of the bed, mostly because of the postural hypertension, all right? So some people would say, when I turn my head, I feel giddy, and I fell, all right? So we have to think about things like carotid sinus hypersensitivity, all right? So depending on the history, you can suspect certain causes, all right? So it's important to ask about their general health. People who are generally unwell, they have higher risk of falling, okay? And if you think about the fall, so you have to elicit whether this is a fall with loss of consciousness or without loss of consciousness. And if the patient can't remember the mechanism of fall, it's better to have eyewitness, but not possible all the time. Yeah. And about the post fall, so whether the patient had symptoms of suggestive of a post-ictal drowsiness in case of a seizure, and whether they were oriented, and how were their mobility after the fall, and very important to three, whether they had a long lie, and get a detailed analysis of the injuries following the fall. Okay, right. And if you look at the false risk factors, I told that most of these falls are multifactorial. They are not due to a single medical reason. All right. So we can divide these factors into intrinsic factors, extrinsic factors, and situational factors. Okay. And we also can divide them as predisposing acute and chronic cost factors and precipitating environmental or behavioral factors. So if you look at this multifactorial nature of geriatric falls, so uh, as I previously highlighted, the fall is a result of a lot of underlying deficits. All right. So interactions among these factors finally result in a fall. It could be just the presentation, but there are a lot of underlying problems. So if you look at the diagram, you can see there are a lot of intrinsic factors, extrinsic factors that can contribute to falls, and there's a final precipitating cause sometimes which result in the fall. All right. So this is the usual nature. All right. So if you encounter a patient with a fall and a fracture, we have to attend to the fracture, we have to attend to the acute medical complication, but don't forget about the fall. All right. So the fracture is due to a fall is due to multiple intrinsic, extrinsic, and situational risk factors. So if you don't find these risk factors and correct them, the next result is they will go home and have another fall and come with the fracture of the other hip. All right. Or a head injury. Right. Right. Okay. So if you go deep into the intrinsic risk factors, so these could be mobility related, this could be sensory functions, this could be cardiovascular, this could be functional dependence, psychological, and urinary incontinence is an independent risk factor for falls. And some of these are medication related problems and nutritional problems, metabolic derangements, and having a history of falls. And if you're older, if you have frailty, there are high risk of falling over again. So you can see there are multiple risk factors for falls, and one patient will have more than one risk factor, right? That's very important to remember. It's not one risk factor which causing the fall. One patient will have more than one of these risk factors. If you look at the mobility related problems, these could be problems with gait and balance, muscle strength, and using inappropriate walking aid or not using a walking aid at all, and foot and sensory problems and fear of falling. So everything are risk factors of falling. And if you look at the sensory functions, visual impairment, hearing impairment, and problems with your uh, balance due to the inner ear problems and neuropathy could be risk factors. And if you look at the cardiovascular problems, orthostatic hypertension is quite common in elderly. It's sometimes not detected, but it's very, very common, and rare to have arrhythmias, but orthostatic hypertension is very common, and sometimes rarely could be due to valvular problems as well. And psychological problems like dementia and delirium are high risk of falls, right? Associated with high risk of falls. And as I previously said, urinary incontinence is independently associated with falls. All right. And I will discuss about medication in a while. And not to forget vitamin D deficiency, like and nutritional deficiencies like B12, folic acid deficiencies, sarcopenia are risk factor for falls. All right. Right. Okay. So if you look at the false risk increasing drugs, so and as we grow older, our number of comorbidities go up. All right. So we keep on adding medications as we grow older. So as a result, most of these patients are on 5 or more medications, including the over-the-counter medications. We call it polypharmacy. All right. So polypharmacy is an independent predictor of falls. If you are having polypharmacy, you already have a risk for falls. Okay. So other than that, there are certain medications which we have recognized as having high risk of falls. We call them FRIDs, falls risk increasing drugs. Okay. Right. So what are the drugs that can increase the risk of falls? If you look at the blood pressure medications, drugs like alpha blockers, all right, and diuretics, and centrally acting antihypertensives have a higher risk of causing postural hypertension and falls. All right. And anticholinergic drugs are not desirable in elderly. All right. So if you are on certain medications that can have an anticholinergic effect on you, these effects they add up. all right? They add up, and if someone's final anticholinergic burden is higher, you have a higher risk of developing certain side effects like dry mouth, blurred vision, urinary retention, and constipation, and it is also a risk factor for falls. All right, so anticholinergics are undesirable in elderly. If your patient is having recurrent falls, and if they are on anticholinergics, you have to consider deprescription. All right, and drugs like antidepressants, antipsychotics also carry high risk of falls, and anti-epileptics as well. And sedative drugs like antihistamines, benzodiazepines, they can markedly increase the risk of falls. All right, so it's very important to go through the patient's drug list and find the FRIDs, for falls risk increasing drugs, and consider de-prescribing these medications. Okay, right. So we discussed about the intrinsic factors, but it's not only about intrinsic factors. There are a lot of extrinsic risk factors that can precipitate a fall. Okay, so these extrinsic risk factors can be categorized as home risk factors, and sometimes in the institution, especially in our hospitals or care homes, and outdoor risk factors. If you look at the home risk factors, things like having a lot of clutter. So if you go to some elderly patients' houses, so there are a lot of clutter. So there is a risk factor for falls, and sometimes all the unnecessary things, children go and put in their parents' house, that increase the risk of clutter and having a trip and fall. And unsecured carpets, unstable furniture, slippery floors, poor lighting, low toilet seats, pets. So all are home risk factors. And if you look at the institutions, right, improper bed height. If you look at the bed height in our hospitals, the bed heights are too much for an older person. So if they get down from the bed, so it's not safe. There's a high risk of falling over. It's not a problem at the moment, because most of the time our patients, they don't get out of the bed. They stay all in the bed all the time. So that's not the, I mean, but it's high risk. It carries high risk of falls and injurious falls, and improper chair heights, improper stair heights, and slip again. Things regard to flooring and lighting, carpets, everything give rise to high risk of falls. If you look at the outdoor environment, again, similar things carry high risk of falls. So just putting you this diagram, this picture, just to look at and identify the falls risk factors, right? So if you look at this, the stairs, so there's an older person coming down the stairs, so you can see there's a box having high risk of tripping over this box and having a fall. All right, and there are no railings. All right, and so it's not a properly constructed stairs for a older person. And you can see there's a carpet here not attached to the floor and having high risk of falls, and wires going across the floor that increase the risk of falls. And you can see there are pets everywhere, so they can increase the risk of falls as well. So I mean, when you design a home environment for an older person, the first thing you have to think is this design safe for an older person? Some of these houses, I mean, might be very well, appropriate for a younger person, but when you grow older, you have to do certain modifications to avoid these extrinsic risk factors. Okay, right. Okay, so we discussed about intrinsic risk factors, extrinsic risk factors, and we are moving to situational risk factors. So there are things like lack of exercise. So if you are having, I discussed that if you are having falls, then you develop fear of falling, and then you become sedentary. So this lack of exercises leads to sarcopenia. All right, and that increases the risk of falls again. All right, so lack of exercise is not a good thing for all adults. So they should have regular physical exercises to prevent falls. And also, in the other hand, high risk activities, sometimes if you are falling over, right, if your balance is not good, certain activities like climbing a ladder might not be a good idea until you strengthen your muscles and balance. And so engaging in high risk activities can carry high risk of falls. Things like alcohol intake and inappropriate use of assistive device. If you're using a walking aid, that should be a prescribed walking aid. If it has if it is inappropriate, that can increase the risk of falls. And also the footwear and wearing things like glasses. The bifocal glasses carry high risk of falls in all adults. All right. So as you can see, the risk factors are complicated.
Yes.
Yeah. So there are multiple risk factors in one patient, right? So how do you assess all these factors? So so there's a specific assessment tool geriatricians use. We call it a comprehensive geriatric assessment. All right? So these patients who present with a fall has underlying risk factors, and they need a comprehensive geriatric assessment and identify all the false risk factors and correct them to prevent a fall. Otherwise, it's very difficult to prevent a fall, right? Okay. The other important thing is, as I told you, so one patient can have multiple false risk factors. It's not only one risk factor leading to the fall. So certain studies have shown if you have multiple risk factors, your risk of falling exponentially increases. In this, in one study, uh, they have shown the one risk factor. If you have one risk factor, they had been about 27% of chance a person is falling. If you have four risk factors, it can increase up to 78%. So in one risk model, they saw these factors like muscle weakness, balance problems, and having more than 4 medications. If you have one risk factor, they were about 12% falls within the next year. If you have all three risk factors, there's a 100% chance that you will get a fall within next year. Right? Right. Okay. Now we have discussed about how common geriatric falls are. We have discussed about the multifactorial nature of the falls. We have discussed about the intrinsic, extrinsic, and situational risk factors for falls. All right. So I'll show you some videos, and so it's your time now to tell us what you think about the mechanism of these falls. All right. 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 So what do you think are the possible mechanisms for first fall, second fall, and the third fall?
First of all.
Right. I think all these falls are multifactorial rather than due to a single reason. If you look at the first person who was trying to turn with the simmer frame, right, and there are obviously problems with their balance and possibly muscle weakness, and there are some other risk factors if you do a complete geriatric assessment which result in the fall. So they might look like a clear slip or a trip, but they are not. They are multifactorial, right? Okay, let's move to the this one. Right, and this one. Right, so they looks like clear slips, aren't they? So there could be clear slips and trips, but most of these things are they are a little bit different from the previous falls, which were patients were more wobbly,
Yes, yes.
right? They had poor balance to start with, so they are multifactorial geriatric falls, and they could be clear slips and trips as well. Right. Let's move to the next slide. Right, what do you think about what is happening here? So what do you think happened there? This looks like a clear faint or a syncope. All right. So it's not a multifactorial geriatric fall. So I mean, it's not always a multifactorial geriatric fall, but most of the time it is like that. But you don't forget about the other medical problems. All right. Okay. The last one. Right. Okay. Right. Okay. So what do you think happened there? So there are environmental risk factors as well. Okay, and some of these elderly patients are they have problems with their vision, they have problems with their cognition. So it's not just accident, right? So there are multiple factors underneath that you have to identify. So when a patient presents with this kind of a fall, sometimes you might think focus on just the fracture or the soft tissue injury or the head injury, and we might record that as a mechanical fall or accidental fall, which is a misnomer. All right. So this patient didn't fall because of accident. So she has obviously some problems with her vision or cognition. All right. That's why she tried to go in the escalator. Right. Okay. So so there are a lot of underlying problems. Right. Okay. Now let's talk about falls prevention. So we discussed about the multifactorial nature of falls, and we discussed that there are intrinsic risk factors, there are extrinsic risk factors, and there are situational risk factors. So identification of these risk factors are very important if you think about falls prevention. All right, and then think about minimizing these risk factors. Sometimes you need a multidisciplinary team to do that, and definitely need multifactorial interventions to prevent a fall. It's not easy business to prevent a fall, but if you sometimes you might not be able to 100% stop patients falling over, but you can definitely, by taking certain interventions, certain steps, you can definitely reduce the risk of falling. All right, and then remove precipitant hazards. Right, and this could be patient focused, or this could be public health focused if you think about preventing falls in the community and in your institution. All right. Right. So let's discuss the case again to apply these principles and see how we can prevent a fall in patient who is having recurrent falls. All right. So this is about uh, a lady, Mrs. Pereira, who was admitted following a fall at home. She reports having 6 falls over last 6 months. So if you can remember the definition, 2 or more falls over last 6 months is called recurrent falls. And she had 3 falls over the last week, right? And she thinks she tripped over a carpet. So these are the common complaints the elderly person will tell you. They will tell, there's nothing problem with me. I just tripped over the carpet. I just slipped over the some slippery floor. All right, and my legs felt weak. My legs gave over. Right. So those are the common complaints. But you need to carefully by that. All right, and comprehensive assess these patients and see what are the risk factors. So she thinks she tripped over a carpet in the bedroom while rushing to the bathroom. Okay, and she was not able to recall the circumstances of her previous falls, even though she had multiple falls. She lives with her daughter and stays alone during the daytime. And the daughter says that Mrs. Pereira has been prescribed a walking aid which she does not like to use. Right. So this is what is meant by the comprehensive geriatric assessment. All right. So if you look at the assessment now, she has in the past medical history, she has type 2 diabetes, high blood pressure, dyslipidemia, knee joint osteoarthritis, urge incontinence, insomnia, and glaucoma. So understandably, because she has multiple comorbidities, she is on multiple medications. So she is on 11 medications. All right. So even the things like eye drops are quite important. So she's on eye drops for glaucoma. So and it's a beta blocker. So and it increases the risk of falling. All right. So you have to adapt everything. All right. And I told you now, she's if somebody is having more than five or more medications, it's called polypharmacy. If you're on 10 or more medications, we call it extreme polypharmacy. This lady is having extreme polypharmacy, which is an independent risk factor for fall. If you look at the medications, so she is on multiple antihypertensives, right? So she is on amlodipine, benfluoretic ramipril, and don't forget timolol is also a beta blocker. All right. So and her blood pressure is 110 by 80, which is not a safe blood pressure at this age. All right. So you target a higher blood pressure target for a person who is falling over 140/90. All right, will be all right. If somebody is very frail, we would go up to sometimes 150 systole. All right, as a safe blood pressure. So if your blood pressure is less than 120, always you need to think in all the patients whether we need to de-prescribe antihypertensives. All right, and you can see the blood pressure drops to 90/70, and she has reported feeling giddy, right, when she get up from the bed. So there's clearly postural hypertension. So drugs like diuretics, all right, and sometimes AC inhibitors can result in postural hypertension. So think about de-prescribing these medications. And also drugs like amitriptyline, right, can, because it also blocks alpha receptors, it can also increase risk of having postural hypertension. All right, and going through the comprehensive geriatric assessment, when you assess the vision is impaired and hearing is impaired, and we performed the balance and mobility tests during comprehensive geriatric assessment, which revealed impaired balance and increased time up and go test. And she can't rise. She's finding difficult to rise from the sitting position, indicating possible lower body muscle strength, possibly due to sarcopenia. And when you do a cognitive assessment, the Montreal cognitive assessment is 20 out of 30, and she has multiple nutritional risk factors. And most importantly, you have to see whether the patient has high risk of fracture, because that's the next complication she's going to have. So she has high risk of major osteoporotic fracture risk and high risk of hip fracture. And she had early incontinence, and there's peripheral neuropathy. And the other important factor not to forget is she's living alone during the daytime, right? So high risk of, if she had a fall, high risk of a long lie, right? And she's dependent for her daily activities as well. And if you look at the examination, she has varying stages of bruising, possibly due to recurrent falls rather than anything else. And she has this kyphotic posture, possibly indicating osteoporotic vertebral fractures. And she is on diuretics, and she is saying marginally low electrolytes, too strict glycemic control. And at this stage, we would try to have a more lenient glycemic control, like HbA1c of 7.58% will be all right for her. And she had low hemoglobin, low vitamin D, which need to be corrected. And she has wedge fractures in the X-ray lumbar spine. So these are the routine things we would do. We will do a medication review, we will do a head-to-toe comprehensive geriatric assessment, and then basic investigations to see whether they have any correctable risk factor of falls. Right. So going through the history, now this patient had recurrent falls. So assessing a patient with recurrent falls is not simple. You can see there are a lot of things we need to focus on, right? Just not the fracture. All right, not only the fracture, there are a lot of other things we have to look into. Right. Okay. Now, if you look at the falls risk factor in this patient, as we discussed, there are a lot of intrinsic factors, and there are a lot of extrinsic factors as well. We identified in the history, but ideally we need to do a home visit and see what are the other correctable extrinsic factors, and then situational factors as well. So the fall happened as a combination of these risk factors, right? Not due to a single reason. So this is a typical multifactorial geriatric fall. All right. So not to forget, she is living alone and she has osteoporosis. All right. So these problems need some intervention to prevent undesirable consequences. All right. So going into the management of this patient, now if somebody is having a fall and having acute medical complication or injury, first priority is to attend to the acute injuries and medical complications, right? And if you suspect a seizure or a syncope, and that needs evaluation, right? And most of these patients, they are not having a seizure or syncope. It's the most common thing is a multifactorial geriatric fall, which needs a comprehensive geriatric assessment, and then multidimensional interventions to modify these risk factors. Sometimes we need a multidisciplinary team for that. All right.
Yes.
So for muscle strengthening exercises, we might need a physiotherapist on board, right? And these multifactorial geriatric falls need multidimensional interventions for risk factor modifications, all right? And sometimes we need involvement of multidisciplinary team for risk factor modification, all right? And we need to regularly review these patients. So, I mean, these risk factors are not going to be corrected within a short period. Sometimes we need to continue our management. We need to do nutritional interventions, balance training, and monitor these patients and review them about monitor their progress. All right. So and not to forget about treatment of osteoporosis, which is quite important in these patients. So this will be the window of opportunity to screen for osteoporosis opportunistically, and if there's osteoporosis, then you can treat and prevent another fracture, right? Fall surveillance is quite important if somebody is especially living alone at home, to alert their carer that they had a fall. Okay, right. So looking at the environmental modifications, I'm just showing some pictures from high resource settings. So these are not impossible. So the handrails has to be installed actually, like most suitably in the both ways of the stairs. All right. And clear clutter from stairs and walkways is very important. And providing adequate lighting in corridors is quite important, especially if you could install a motion sensitive light. That will be quite useful. When the older person enters the corridor, the light lights up. All right. And look at these modifications. So if you have rugs or carpets, you can use slip resistant rubber backing, or you can use some velcro tapes to attach the carpet onto the floor. So these carpets should not be uh, hazardous. And looking at the kitchen modifications, the food dishes and cooking equipment should be in a desirable distance within reach. And if you look at the bathroom, all right, so most of these patients, sometimes they can't get up from lower bathroom seats, all right, lower commode seats, right? And you can use a commode seat raiser like this, all right, or you can also install grab bars, folding grab bars like this, right? Okay. And most important, the floor also should be non-slippery. Okay, so you can do some modifications in your living room, bedroom, kitchen, and bathroom to prevent falls. Okay, right. So looking at some other options, so these are anti-glide socks which can be used especially in hospital or institutional environments to prevent a fall. And so we talked about false surveillance. So these are some false surveillance instruments which we can use. So if you are having high risk of fall, so you can wear a false detector or a kind of a pendant alarm. When you fall, you just press the button, it will send the alert to your loved ones that you had a fall, so they can come quickly and give take you to the hospital. And so these are actually you can get from eBay, right? These are elderly false detection devices. There are a lot of things actually which we can do for false prevention and alert a patient when they have a fall. Right. So if you think about in-hospital falls, I'm sure you must have encountered one or two patients who had a fall while in the hospital. So hospital is not a safe environment for the patients. So if you look at these risk factors, there are a lot of patient risk factors and environmental risk factors which can contribute to falls. All right. Especially if someone is cognitively impaired, right? If you have wandering, there's a high risk of falls. All right. And things like postural hypertension, because most of these patients are on multiple antihypertensives, they are partially dehydrated when they are in the hospital. So they have very high risk of fall, and they are acutely deconditioned because of the acute illness. And the physical environment in the hospital, if you think about, are very complex and not elderly friendly. And the restraints can lead to injurious falls. And the hospital environment is full of clutter, and there's suboptimal lighting, and bed heights are not suited, and we don't have enough adaptations. So if you think about the environmental adaptation I have just discussed and compare with the hospital environment, and we don't have appropriate modifications, and this leads to the risk of in-hospital falls. Could be in walkways, could be in stairs, could be in wards. And so building awareness is quite important, which we are doing now. And identifying high risk patients is very important. If somebody is having wandering, somebody is cognitively impaired because of dementia or delirium, we need to monitor them quite frequently to prevent a fall, and focus on environmental modifications. And for high risk patients, we can use anti-glide socks and medication review, not to forget. Right. So if you think about prevention of falls uh, more widely in a community point of view, so there's a WHO falls prevention strategy where they discussed about three pillars. First thing is obviously building awareness, uh, awareness between the doctors and also the carers and patients. And pillar two is identification and assessment of risk factors, which we have just discussed. And it's important to uh, do community level screening for all adults, and see as a when they present to the medical clinic, opportunistic screening of these false risk factors and correcting them. wherever possible is quite important. And pillar 3 is to implement the realistic interventions, and we need national policies and funding. And even when we design our institutions, when we are designing our cities, they should be elderly friendly. So I discussed, now we are reaching 25% of our population being older than 60 years by 2040. So we are categorized into this group of countries, which is called super age countries. So we need to design our public institutions, cities, in using these strategies, which will be more elderly friendly, and using strategies to prevent falls. Right. So one slide about osteoporosis, because this is something which we forget to screen when somebody with falls presenting to you. Even after a person with fracture, sometimes we forget to assess osteoporosis and manage osteoporosis. So one of the complications of fall is getting a fracture, right? So osteoporosis can first start with a Colles fracture. Sometimes people have vertebral fracture which go unnoticed. So then they can be multiple vertebral fractures. Ultimately, they can have a hip fracture. All right. So this is called osteoporotic journey, right? So if you detect somebody at early stage of osteoporotic journey, then treat for osteoporosis, and that will help to prevent a second fracture. Okay. The opportunistic screening is very important, especially in these patients who are having recurrent falls. As I said, if you have one fall, there's a high risk of having a second fall. So use that golden opportunity to screen for osteoporosis. And if you have osteoporosis and detect osteoporosis, treat osteoporosis. You might sometimes not be able to prevent a fall, right? But if you have started an osteoporotic treatment, you might be able to prevent a fracture. All right, so that's been shown statistically in other countries. So sometimes, even though you do multiple interventions, so the degree to which you can prevent a fall can be limited, but you can prevent a fracture. All right, so it's very important to screen for osteoporosis and treat osteoporosis. So there are simple tools like FracScore, which is validated for Sri Lanka, can be used in your clinic settings, in your ward settings. And remember to add 30% correction if you have high risk of falls. All right, so you don't have to do a DEXA scan. All right, you can do a FracScore, and if FracScore is more than the intervention threshold, you can treat for osteoporosis. All right, and there are some other scores like fracture score, fracture score, where you can incorporate the falls risk into the equation, but those are not validated to the Sri Lanka setting yet. And the other important investigation is DEXA scan. You can get an idea about the bone mineral density, right? But don't forget, bone mineral density is not the only risk factor for a fracture. All right. So if somebody is having recurrent falls, right, and if they are having osteopenia in DEXA scans, still there's a high risk of getting a fracture. All right. And screening for vertebral fracture is very important, especially if somebody is having chronic back pain, if somebody is having kyphosis, and if somebody is getting, they will say, my mom used to be tall, now she's a little bit shorter. So this is due to osteoporotic vertebral fractures. All right. So simple investigation like X-ray thoracolumbar spine might show you wedge fractures like this, which are diagnostic of osteoporosis, right? And you can straight away start treatment. All right. Okay. Right. So in summary, so falls are common among older adults. So, and falls associated with high degree of morbidity and mortality. And as we discussed, causes of falls are multifactorial. So we need a comprehensive geriatric assessment to identify these multiple risk factors. And one patient will have multiple risk factors. That's the challenge, right? So you need multidimensional interventions for which you might sometimes in a multidisciplinary team to prevent a fall. All right. So I have stopped. These are my references. I have finished a little bit early, so I am happy to answer any questions.
Yes, sir. Uh, Okay, sir. I'm having one question over here. Have we got kind of programs to educate our elders about their old age falls and effect on longevity, and educate doctors or medical students as well as healthcare workers? Is there any program?
Actually, at the moment, we don't have a national program to educate the elders, but we are doing education through our elderly care clinics and forums like this. So I think still there's a lot of lack of awareness among older patients as well as healthcare staff and carers about falls. And some people think falls is a part of old age rather than a disease. So we have to look at falls in a different way and need to educate the public, educate the health staff more, and look at falls as a disease rather than a symptom of old age.
That's the thing. So until today, even us, we were not aware about that, sir. Sir, there's another question. Could you be able to explain about hypostatic pneumonia? You said like staying more than 1 hour on after a fall on floor could lead to hypostatic pneumonia.
Yeah, so I mean, most of these elderly patients, they have very low muscle mass, they have sarcopenia, they are frail, so they are more prone to get basal atelectasis when they are on floor for a long time, and then it's a risk factor to get infection on top of that. So it's a risk factor for falls.
Right.
Yeah.
Right, sir. I think that's all with the questions for the time being, sir. As usual, Dr. Sithira always brings something new to the table. And I'm sure that following this lecture, we all could add a new dimension to our history taking and counseling of elderly patients. So I thank you, sir, for that awesome lecture and hope to meet you again with such new information to us. So until such time, I bid you well and take care. We'll meet you again with such lectures with GMOA Academic Cover. Thank you.